Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Cristina Gasparetto, who's professor of medicine and one of the luminaries in multiple myeloma therapy in the country. She is going to talk to us about how she uses Selinexor in her practice. This is an area where she is been well published and has done a lot of research. So welcome, Cristina.
Thank you. Thank you so much for having me here today with you and have the opportunity to talk about Selinexor today with you, of course.
No, nobody can talk about this better than you. So the question is, first of all, for our audience, what is Selinexor?
Selinexor is very interesting drug because it's not specific for myeloma. In fact, it has been used for different type of cancer, solid cancer and other blood disorders. And so what Selinexor does, inhibit a protein that is expressed in many cancer cells, and myeloma, of course, is called exportin-1. And the function of this protein is to bring out some of what we call the cargo, oncoprotein, tumor suppressor from the nucleus to the cytoplasm. So the cells continue to grow, to proliferate. And so Selinexor blocks, inhibit this protein, and so the cargo stays in the nucleus, and the cells eventually go to cell death, apoptosis. We stop the proliferation. But as I say, what is different of this drug is oral, as you know, is given by mouth, is not specific. And what we have learned about this drug, we've learned a lot also when we use it, has been used for other cancer, like the tissue penetration, the fact that it's been used also for CNS cancer. And so we know that there is some CNS penetration, etc. So it's different, it's a new target.
So can you tell us about the drug and its development? I believe that it was initially approved for use twice a week, but that is, I think, very rarely done, and that was in combination with dexamethasone. But the first, three-drug combination that allowed it to be used once a week and allowed it to have a much better safety profile was the STORM study. So could you just give us the highlights about this study?
Yeah. So the STORM study, it was the first study to introduce Selinexor for patients with heavily pretreated myeloma. And back then, is a little bit before the fancy immunotherapy. So these patients were heavily pretreated. They received many lines of therapy. So they were receiving this oral combination, Selinexor twice a week, like you mentioned, and dexamethasone. And there was a signal, right? About 30% or so responded, which was a big deal because this patient had failed everything else. And the problem is that it was approved by the FDA, but like you mentioned, it was given twice a week and is associated with a fair amount of toxicity. And so it was difficult for patients to tolerate the Selinexor given twice a week. And I always, when I explain about the toxicity to patients and when I teach about Selinexor, I always tell them, just think about the toxicity, three things you have to remember: the constitutional, the weight loss, the profound fatigue, and then the GI. Nausea is a big deal. These patients receive a lot of antiemetics before getting the Selinexor, the GI toxicity, and then the low blood count, the myelosuppression, the decrease of the platelets, red cells, white cell count, that we call myelosuppression. And so it was difficult to sustain patients. They had to receive a lot of supportive care. And some of the physicians, when they started to use this combination, they got discouraged. And that is how the Selinexor was introduced. So had this bad reputation that it was poorly tolerated. And then we launched the STOMP trial, and the STOMP trial came a little bit later. And I remember being involved on the STOMP from the very beginning. Yeah, and
Want to get to the STOMP study?
yes,
Yeah.
the STOMP study, yes, perfect. And so the idea was to use selinexor in combination with different myeloma backbone. So we actually use it with everything, with the IMiDs, the proteasome inhibitor, with some of the antibodies, and it became clear from the very beginning that we didn't need such a high dose. The twice a week was too much. And so once a week, and some of the combination, you really don't need high dose of selinexor. And some of the combination were very effective. And one of my favorite, if I can say, is with the carfilzomib, because as you know, a lot of patients receive RVD, transplant, Revlimid maintenance. Then one of the most used first salvage therapy was the Darzalex with the Pomalyst for convenience. And then, you know, the next is the carfilzomib, but we really didn't have a good companion. And so this became a very good companion for carfilzomib. And the responses were very high. We had about 70+%, including a lot of patients who were refractory to Darzalex, which is very difficult patient population to treat. And so it became clear, and even my surprise, I was kind of concerned at the beginning, but when I started to use, I had patients sustaining for a few years and with excellent responses. And it was clear that the selinexor was effective, but the key was that was given only once a week. And as I mentioned, you know, the three categories of toxicity were real, but mitigated. So the majority of patients had the nausea, the fatigue, the GI discomfort, the low blood count, but mitigated by the fact that now the selinexor was given only once a week. So the majority of patients were experiencing grade 1 and 2 toxicity. And so it was definitely very manageable, and patients were able to sustain therapy for a long time.
So what is the dose of selinexor? I know you mentioned that you use it once a week, but even
Yes,
the once a week regimens, the doses can vary depending on what you're combining it with. So
correct.
what are the doses that you tend to use?
So, you know, it was approved in combination with bortezomib, which is one of the arm of the STOMP study that was brought to a phase 3 randomized study at 100 milligrams. But I think is too high. And even 80, I think the sweet spot is between 60 and 80. If you combine it with the IMiDs, because the low blood count, the myelosuppression is more pronounced, 60 is enough. So it depends on, again, the companion, the different backbone, but between 60 and 80.
I know that in combination with pomalidomide, some are using even 40 milligrams, I think.
Correct, you're right. In fact, when we started the POM with the selinexor, the first few patients experienced low blood count, neutropenia, with febrile neutropenia being one of the SAE, the toxicity that we were, you know, the STOMP study was designed that each arm at the phase 1 where we're funding the dose, and then based on the dose, then we were spending on a phase 2 portion. And you're correct, the 40 milligrams was with the pomalidomide. When I do pomalidomide, I think about a lower dosage. Sometimes I start a little bit higher and I de-escalate very quickly after the first cycle.
So you obviously have studied a number of these regimens. It seems like
Yes.
with Selinexor, Kyprolis Dex may be your favorite. What are some of the other Selinexor-based regimens that you use in your day-to-day practice?
So the Selinexor Darzalex was also a very good one, but the majority of patients were exposed. You know, it was very difficult to find a patient that never received Darzalex. And actually on that, the Darzalex Selinexor arm, we had 2 patients who received Darzalex before, and both they didn't respond. So we knew that but that was a very well-tolerated combination. With the IMiDs, like you mentioned, we had more myelosuppression, more kind of low blood count, cytopenia, the low white cell count and anemia, and of course the low platelets, because there is direct effect of selinexor. And so with the IMiDs, we didn't have great results with others, like with the Nilaro, which we tested quadruplet with the ilotuzumab and was too toxic. And we're actually expanding now. We're going to have a new arm, believe it or not, with some of the new IMiDs. So that will be very interesting because, again, the fascination of some of the oral combination, right, for patient, for convenience, can we use all oral agent, and so we're always looking for the next combination.
Yeah, I think that XPD, the all oral, is often an attraction
Yes,
for
yes,
patients.
yes.
So the thing is that obviously we've gone through some of this data about the durability of some of these responses being even stretching out more than a year.
Correct,
And
correct.
as far as the side effects go, though they have been mitigated, what are the side effects that are most pronounced? And then we'll come in a minute to how we can try to mitigate them.
Correct. So when I sit down with a patient, I always talk about, the first month is going to be the most difficult because the nausea, I think, is, probably the number one. And, patients having nausea, they have decreased appetite, they don't feel well generally, extreme fatigue. So the nausea is the big deal. And some patients have a low appetite and the weight loss. So you have to counsel them. How can you overcome the nutrition, the nausea, and then fatigue. And then the other big one, and with the double, with the twice a week selinexor, we also had problem with electrolytes, particularly the hyponatremia, the low sodium. With a single dose administration, you still have to look for electrolytes imbalance, but not at that level. And then, the low blood count, the anemia, the low platelets, and the low white cell count requiring some supportive cares. But again, I go back, I talk about the fatigue, the constitutional, the GI, the nausea, some diarrhea, and then the low blood count.
So how do you, where do you incorporate selinexor-based regimens? I think we are in a very fluid environment right now with the recent approval of CAR Ts with second plus line of therapy even. But first, before that approval, where were you using it, and what do you think that the approval of CAR Ts in earlier lines of therapy will mean for your utilization?
So, as part of the STOMP trial, I use it a little bit a different level because I was channeling patients based on the prior lines of therapy. As I mentioned, I love the combination with carfilzomib, so I used a fair amount of carfilzomib selinexor. And then sometimes I even go back to the bortezomib. We haven't talked much about the Boston trial, but we have learned a lot from the Boston trial. Where now selinexor was combined with bortezomib given once a week. And sometimes I actually went back to bortezomib with successful results, where I had patients failing, the carfilzomib, and then I went back to selinexor or bortezomib, and I was able to recapture the response. So, it's, as you mentioned, it's by mouth, so with the IMiDs, however, I'm very concerned sometimes in certain patients, sometimes the more frail patients about the low blood count. But I use it a lot with carfilzomib and bortezomib. And I like the fact that in the Boston trial, I don't know if you want to go back to the slides just for reference, but what the sponsor did, which was very important, is on the arm where patient receive selinexor, the bortezomib was only given once a week. And with the dexamethasone also at the lower dosage. And despite that, it was a successful study, meeting the endpoint of the study, the progression-free survival. And what we have learned from this study, and I always, when I'm sure you do the same, when I review a study, I kind of dissect the different population of patients, right? Older, younger, renal dysfunction, high risk, to see, is this combination going to be a good combination for my patient? And we had great results on patient refractory to Darzalex, patients with high risk cytogenetic, particularly the deletion 17, patients with renal insufficiency. They're okay to tolerate this combination. And again, the FDA approved the Selinexor 100, but I don't think many of us actually use 100. I use 80 out of the gate with less toxicity. And so we learn a lot from this study, and the fact that we could manage toxicity, like you mentioned, how we can use the antiemetic before we start. And we learn also that some of the toxicity was going down with time. Like you see the nausea the first month, and then it dissipates with time. So I use, and you mentioned about the CAR T-cell and immunotherapy, but it's becoming a good bridging therapy, actually. And we do have studies, even at Duke. My colleague, Yubin Kang, is doing a lot of reconstitution, a lot of study on the T-cell function. And we saw that actually there is induction of CD8 T-cell with Selinexor, further, studies eventually, but can the Selinexor be used before or after CAR T-cell, before or after bispecific for the function? It doesn't really affect the T-cell. It can be used safely before the collection. We had problem using alkylator chemotherapy because we suppress. And now with Selinexor, so I still use it. It's a good bridging therapy. I still use it as a good backbone for some of the other strategies, and I think there is going to be a space. And I'm actually surprised that we haven't used it more in patients with high risk disease, with the high risk genetics, the ultra high risk with multiple genetic abnormality. And also another space, I know there are some studies ongoing, but like I mentioned at the very beginning, the CNS penetration. We don't have much for this patient. Thank God it's very rare, it's not very common, but I've used it. I've used it in combination with Pomalyst, for instance, because both drugs have CNS penetration, and I've used it. And is an oral combination, why not, with some CNS penetrations? So, learning about the drugs, and I think, it's, again, it came with a bad reputation, but I think, the field, hopefully we can actually utilize these drugs more, particularly in the era of all this new immunotherapy. How can we, strategize?
Yeah, and though CAR Ts have moved earlier, there are still going to be, I think, few patients getting them in second line, and we do get patients who
Yeah.
are triple refractory, sometimes even in first line. So I guess a selinexor-based combination, even in the era of earlier CAR T cell therapy, will offer, as you said, a good attempt to not only bridge but also conducive to be given before the collection itself. So.
Correct. Right.
And
And
then,
even after, some of the preliminary data show that you can rescue patients
yeah,
after
that's
failing.
exactly what I was going to say. And we
Ah,
already have data, I think, that people who have progressed after CAR T
correct.
do have response to selinexor-based combinations. So
Correct.
the other thing that I guess we're going to talk about is your strategy on how to mitigate the side effects. Certainly, bringing down the dose, bringing
Yeah.
it to once a week has helped. But what is your strategy? How do you practically manage? You mentioned that if you get patients through the first cycle, often it is much easier after that. So what are the measures that you take?
So for the once a week administration, starting the ondansetron, 8 milligram before the dose and every 8 hours consistently. Very important. And then I use olanzapine at bedtime. And after a couple of months, the patients don't need the olanzapine at bedtime anymore, and they start to, come out of the dose of Zofran. And then occasionally, with the biweekly administration, patient needed 3 antiemetics, but with the weekly administration, I think they're doing very well with Zofran, with ondansetron and olanzapine at bedtime. And then I always, like you mentioned, de-escalate. So if a patient is responding rapidly, and they do respond within the first cycle, I go down if the nausea, the fatigue. But as I mentioned, and we saw that in the Boston study, the nausea will dissipate with time. Patients will become used to. But then I counsel them, nutrition is very important, maintaining a good protein intake, nutrition. We're talking a lot about the importance of the diet in patients with myeloma. And in fact, Dr. Shaw Orvi in New York, she convinced me a couple of years to become vegetarian. And I'm sticking on that. I love it. But a lot of data to support, the importance of the inflammation. But nutrition, fluids, correcting the electrolytes, some counseling at that level. And as I say, so far, and I've used it a lot, because part of the STOMP trial, and the STOMP was during the COVID, and lots of the CAR T-cell immunotherapy shut down for a little bit. So I use it in a lot of patients because of that. And with surprise, some successful stories, patient remaining on therapy for a few years. But the counseling is, again, nutrition, IV fluids, the anti-nausea. And no, one thing I forgot. I used to use growth factors. And in particularly for the platelets too, I had to sustain I have few patients that were really averaging low platelets count, around 20, 30, that I use growth factors, and with, good success.
Do you use an NK1 antagonist for all your patients or not really?
No.
I think that was probably a legacy of the twice a week schedule that
Yes.
was
Yes.
made popular by some. And do you tend to bring patients in for IV fluids or just only if needed?
The first cycle, I bring them once a week, just because there is a little bit, the fear, and sometimes support them with fluids and make sure that they're okay. And that's it. And then, one of the combination with carfilzomib, they come once a week, but with the oral, after a certain point, they were okay. We even had a harm for newly diagnosed with the lenalidomide. The response was enormous, and was all oral regimen. With the Darzalex, I had patient coming monthly after, they went to the Darzalex every month. And so, at the beginning, we keep a close eye, particularly on the electrolytes, the fluid, the nutrition, and then they kind of adjust.
Anything for appetite stimulation or not really?
I have not used it much with a single dose. No, really. No, I remember one patient, one young woman, they lost a fair amount of weight, and then we dose adjusted, and my gosh, she's was back to normal very quickly. So no, really, no.
So obviously, as we end, you mentioned that you are talking now about combining these with the newer generation of oral drugs, the cell mods, I presume. Are there any other combinations that you think are ripe to be explored among the other new entrants into the myeloma field?
Well, I always question about the venetoclax, for instance. I really believed on personalized medicine, targeting, certain genetic aberration. And so I was always interested in, as an oral agent. With the venetoclax, you have single agent 40% response in 11-14 goes up with the DEXA. And then some of this combination, they're still under investigation, with the proteasome inhibitors and etc. So I always thought that we didn't test it with Sarclisa, with isatuximab, and in my opinion, there is a little bit difference between isatuximab and Darzalex. I will have loved to test it with isatuximab. We didn't have great results with the Nilaro, with the ixazomib, but I always seek, an oral combination, because at a certain point, we have this cumbersome therapy infusion, and at a certain point is good for patients, spending time with their family and convenience, improving their quality of life.
No, I agree that this is a drug that for some reason has also been underutilized, and I think that the once a week schedule that you have studied in combination with a number of agents has made it much more tolerable. And in the era of immunotherapy, it has a role both before and after immunotherapy.
We're launching a clinical trial, Dr. Kang, again, at Duke with me, where we are using a post-immunotherapy as a maintenance because the stimulation of the CD8 and the function in the immune system, and we'll see, could be also a good drug in a maintenance setting at very low dosage.
And talking about maintenance, I think there are trials ongoing even after post-transplant maintenance. I
Correct.
believe an Australian study, randomized study.
And I would love to see, particularly in the high-risk disease, because definitely there was, the efficacy even on the high-risk genetics was pretty good.
Well, Cristina, I can't thank you enough for taking the time today and educating us about Selinexor, and hopefully the trials that you're doing and the research with this molecule will continue to provide even more regimens for patients in the future.
Oh, I hope so. And thank you so much for having me.
I look forward to having you again.
Thank you. Thank you.